Okay, so good afternoon everybody. Today we are going to present the paper, The Incentive to Treat, Physician Agency and the Expansion of the 340B Drug Pricing Program by Danea Horn, published in the Journal of Health Economics 2025. This paper asks an important and somewhat uncomfortable question. Does a program designed to support safety net hospitals actually influence how physicians prescribe, and is it always in the best interest of the patients? The 340B program allows hospitals, the safety net hospitals, to purchase drugs at discounted prices while still being reimbursed at full price. This creates a financial margin, so because they keep the difference, and so this study examines whether these incentives actually influence the treatment decisions and do they actually impact patient outcomes.
Now, yeah, I think it's going to work.
Okay. So we will begin with the introduction and the detailed background of what the 340B is all about. Then my colleagues will explain the data and the descriptive statistics. We will discuss the impact of this program on the treatment and outcomes, and also the provider and patient selections. And finally, we will summarize the key findings, what they mean, the economic interpretations, and also then close with the final conclusions. Okay, so what exactly is the 340B program? This program was created in 1992 by the US Congress under the Veteran Healthcare Act to support safety net providers, that is, hospitals that serve low-income and uninsured patients. So, and this is how it works. The hospitals can purchase outpatient drugs at 25 to 50% discount, and the insurers reimburse them at full price. So this creates a financial margin and also a potential incentive to increase drug use. This program has grown significantly from $8 billion in 2013 to $42 billion in 2021 with over 52,000 sites. And it accounts for 14% of the all brand name drug sales. So this is no longer a small program, but a major force in the healthcare system. So this is what the study examines, whether these financial incentives impact the treatment decisions and subsequently the patient outcomes. So we already know that hospitals do respond to these incentives at the organizational level. For example, by expanding the drug-intensive treatment services like oncology. But what we need to understand here is whether these incentives reach the individual physician, and does it actually affect what the individual doctors prescribe to the patients in front of them? Because ultimately the patient outcomes depend upon the individual prescribing decisions. So this study focuses upon breast cancer treatment, and that is a deliberate choice for the following reason. First, this is the most prevalent cancer, one of the most prevalent cancers in the United States. Secondly, it uses drug therapy across all stages, making prescribing decisions central to care. And thirdly, there are multiple high-cost treatment options, and that gives flexibility to the physicians in choosing the treatment. So this creates an ideal setting to observe whether these financial settings actually influence the prescription behavior. So the key approach is to understand what happens when a physician joins a 340B hospitals. So the method is to compare what happens before and after joining, and also compare their prescribing patterns to the physicians who never joined the 340B as a benchmark. So since the prescribing patterns of these physicians was similar to other physicians, any changes observed afterwards could be attributed confidently to joining the 340B hospital. So this gives a clear and rigorous framework to interpret these changes. And now I will hand it over to Kanat to explain the data and the descriptive statistics in detail. summarize the key findings and what they mean. The results are striking. After joining the 340B hospitals, physicians treat 26% more patients with drugs. The treatment claims per patient increased by 40%. More drugs are used to treat.
How much percent did you get?
40%.
40.
Yeah, it was in the graph. If you see Beyond's graph, it was like 1.4, and so that is like about 40%. So more drugs are used to treat side effects, and there is high use of opioids like fentanyl and morphine, and increased use of bevacizumab, a drug which is no longer even approved for breast cancer treatment. So clearly, treatment intensity increases. And so while the treatment is increasing, so what about the outcomes? 1 year mortality remains unchanged, long-term mortality remains unchanged, hospice use remains unchanged, and survival gain is less than 1 additional day. So clearly,
money well spent.
Yeah, so there is no significant improvement in the
about
outcomes.
$41 billion here.
Yeah. So the empirical findings show a clear pattern: more cost, more drug, more side effects, more treatment, but without improved outcomes. So from the health economics perspective, it can be explained from both the demand side and from the supply side. Adverse selection explains which patients come in. So usually the sicker ones, but the physicians, the increased treatment comes from doctors responding to the financial incentives. So more care does not always necessarily mean better care. The patient outcomes are shaped according to the interaction between information asymmetries and incentive structures. So patients rely on doctors, but doctors are responding to the financial incentives. So finally, there are 3 key takeaways. First is an unintended consequence. A program that is designed to support safety net hospitals is creating financial incentives that influence prescribing behavior. Second is the real trade-off. The 340B program does provide important financial support to safety net hospitals, but it leads to increased treatment without improved outcomes. And thirdly, there are better policy alternatives like the direct drug pricing program under the Inflation Reduction Act that can help us achieve similar objectives, but without creating such prescription incentives. And so finally, I'll just introduce this and then we will take over that financial incentives in healthcare, they do reach they extend to the point of care, affect the decisions which are made in the exam room. And this study shows the importance of designing policies that align the physician's incentives with the patient-centered outcomes and not necessarily increased utilization.
And finally, I'm not going to talk much, just one line. That is like, so what does it say? Like already Rita kind of mentioned that more care doesn't mean that better care. And this